Hi, my name is John Aaron Avalos, and I am a BSN student at Indiana State University. This is my presentation on the opioid crisis for population-focused community health nursing. My population at risk is men and women in chronic pain, ages 25 to 54 years old, addicted to opioids. In 2019, an estimated 10.1 million people aged 12 or older misused opioids. Specifically, 9.7 million people misuse prescription pain relievers. Every day, 91 Americans die from opioid overdoses. My objectives for you to learn this by the end of the presentation is to know what the opioid crisis is, how it affected the United States, types of medical and non-medical use of opioids, risk factors, signs of addiction, pain management, consequences of opioid addiction, the interventions and harm reduction approaches. Please pause the video for a pre-test. Click the link below in YouTube. Not going to cover everything because the information is just too much. I'm only going to click or highlight the most important things. Opioids are now the most prescribed class of medications in the United States. In 1 year alone, U.S. retail pharmacies dispensed 245 million prescriptions for opioid pain relievers. Of these, 65 were for short-term therapy, and 9.6 million to 11.5 million persons were prescribed longer-term opioid therapy. Opioids are widely diverted and improperly used. 37% of the 44,000 drug overdose deaths were attributed to pharmaceutical opioids. There has been an increase in the rate of opioid addiction, affecting approximately 2.5 million adults. The major source of diverted opioids is physician prescriptions. How did this crisis begin? In 1995, Purdue Pharmaceuticals received approval for OxyContin, which was a powerful new pain medication. People immediately got addicted. In 2007, Purdue paid $634 million in fines for lying about OxyContin, which they claimed was less addictive. Prescriptions for opioids tripled between 1991 and 2011. Doctors started overprescribing opioids, and opioids flooded the market as they fell into the wrong hands, such as drug dealers. In 2010, Purdue released an abuse-resistant type of OxyContin so people couldn't inject it. It turned to goo if somebody was trying to inject it. At the same time, doctors became reluctant to give opioids to patients, so prescriptions began to decrease. What this did was it spurred on the heroin epidemic because chronic pain patients were no longer able to get OxyContin, and they had to turn to the streets to get something to relieve their pain. This is a graphic for the opioid epidemic by the numbers. Financial cost of the epidemic. Researchers have estimated that the epidemic's cost to the nation was at $504 billion in 2019. Criminal justice costs in Boston alone for May 2018, it estimated corrections, probation, parole, judicial, and legal fees at $5,649,000,000. Treatment costs such as naloxone and Narcan for first responders. Each state has been allotted $1 million for first responders. Health complication costs. Complications such as infants being addicted to opioids as they are born. The average cost of an infant addicted to opioids in the first year of life is nearly $70,000 more than the cost to care for an infant that is not addicted when they are born. Productivity to labor markets. We have an unusually large number of people in their prime working years who are not in the labor force. The United States has the lowest labor force than any other advanced country. This is attributed to the opioid epidemic. What is this doing to families? Well, now you have people that are supposed to be retiring, getting second and third jobs to raise their grandkids because their children are addicted to opioids. Basically, the regulatory failures, the U.S. Food and Drug Administration did not regulate the opioid manufacturers as they were disseminating false claims about the risks and benefits of opioids. The failures. In 2007, the President's Commission on Combating Drug Addiction and the Opioid Crisis found that the opioid crisis was caused by inadequate oversight by the FDA and the NIS. The FDA was wrong to allow promotion of opioid use for chronic pain. They also did not properly enforce the Food and Drug Cosmetic Act, which basically was an application for extended release OxyContin. The labeling should have been more strict, and instead it was very general, which allowed broad allowing of Purdue to promote the drugs for common conditions such as back pain, fibromyalgia. Also, conflicts of interest. 11 of the 16 FDA medical reviewers involved in approving 28 products now work for the companies whose product they regulate. There's also been some very good regulatory successes. Post-surgical injections, basically, they don't give any opioids after surgeries. They just give injections, which has cut down on the addiction. The Post-Operative Opioid Prevention Act of 2018 encourages the use of non-opioid analgesics in post-surgical pain treatment. The Medicaid Opioid Safe Treatment Act, it spurs the development of medical devices such as digital health technologies, diagnostic tests, and novel solutions to detecting and treating and preventing addiction, addressing diversion, and treating pain. The Substance Abuse and Mental Health Services Administration is working to reduce the impact of substance abuse and mental illness on America's community. Their focus is on areas of the greatest need in the communities, including increases to access and treatment, reducing unmet treatment needs, and reducing opioid-related deaths. The U.S. Department of Health and Human Services is working on gaps of inconsistencies in pain management. They are providing the public and communities with an opportunity to comment on any proposed updates, and they are developing a strategy for disseminating information about best practices throughout community-based populations across the health continuum. This is a slide on the names and use of opioids. Non-medical use of opioids is basically all bad. Getting opioids from friends or relatives, getting multiple prescriptions for it, and using unethical prescribers. Risk factors for opioid abuse: genetics, previous history of substance abuse, environmental influences such as exposure to sexual, emotional, physical abuse, stressors, being around people that are using, easy access, psychological factors, depression, anxiety, age, chronic pain, method of use, pain management. You have to use a comprehensive, holistic assessment using evidence-based practice to formulate plans of care for community-based populations across the health continuum. Pain management is whatever the person says it is. It is subjective. Pain is an important component of a physical assessment. There are numerous scales that nurses use to determine pain. You can use a numeric scale, a FACES scale, or based on their actions: face, legs, activity, crying, and consolability. There's also screener assessments for potential abuse. The screener and opioid assessment for patients with pain uses 24 items to predict if a patient will become addicted to opioids. Brief pain interview. There are holistic approaches such as the gentle jogger. It releases nitric oxide by stimulating the feet, tapping on the ground. Assess controlled substance prescription history, drug monitoring programs, access to multiple prescribers, early refill requests, determining whether opioid dosages are appropriate. All of these things are ways to track if a person is accessing or using the opioids correctly. Non-pharmacological ways to treat pain: hypnosis, comfort therapy, physical and occupational therapy, psychosocial therapy, neurostimulation. Several consequences of addiction, mostly overdosing, death, family problems, lifelong legal issues. Health effects: respiratory problems, seizures, spontaneous abortions, loss of appetite and weight, and nausea. There's several wonderful interventions now being implemented throughout all communities in the United States by law enforcement and by communities. Strategic family therapies, medication-assisted therapies, inpatient, outpatient treatment, peer recovery services, community reinforcement approaches, complementary interventions which are all community-based, transportation to and from treatment, specialized living situations, recovery houses, recovery-friendly workplaces, faith-based efforts, self-help and support groups, awareness, education, stigma education, education and support, partnership with local and regional prevention coalitions. All of these are community support programs. Harm reduction by law enforcement. There are many things that law enforcement now is doing to prevent opioid addiction and overdose. Public health officials are expanding access to evidence-based treatments throughout the United States, enhancing evidence-based harm reduction efforts, expanding access to recovery support services. Here are some additional resources for you to look through to help on opioid addiction. Please take a moment now to take a post-test on YouTube. Click the link. Here are my references.